A very good evening. Today I'll be presenting a tale of two trauma, which means a visual outcomes in closed lobe injuries with and without head trauma. Ocular trauma has a wide variety of presentations ranging from a contusion to a globe rupture, and a patient presents with a vision of 6/6 to patients with no perception of light. Our main aim of the study was to analyze the influence of head trauma in the visual outcomes of patients with closed globe injuries. It is a cross-sectional study of study duration 3 months. We took 300 patients and they were broadly classified as group 1 who had both closed globe injury and head injury, whereas group 2 who presented only with a closed globe injury. We included the age group of 18 to 65 years. Patients with severe head trauma with GCS less than 9 and an open globe injury was excluded from our study. Visual acuity during the first presentation of the trauma and at the end of 2 months was recorded. We also took factors like a concomitant head injury, a lid involvement, a bony orbit involvement, and their influences on visual outcomes in both the groups was analyzed. Results: in our study, the predominant age distribution was of a younger age group, less than 30 years in both the groups, and it was a preponderant male gender was involved in our study. The causes of closed globe injuries in both the groups was road traffic accidents, and the ocular manifestations in group 1 who had both ocular trauma and a head trauma was papilledema, whereas in group 2 it was subconjunctival hemorrhage. We also took into account the impact of GCS on visual outcomes, where we saw that in patients with moderate head trauma, that is GCS of 9 to 12, 38.9% of the patients improved in visual acuity, whereas in mild head trauma, it was more, 56% of the patients showed an improvement in visual acuity. Visual outcomes in patients with papilledema, in group 1, it was 27.3% of the patients, whereas in group 2, all 100% of the patients showed an improvement. Here, we also account the papilledema in group 2 patients who presented only with the ocular trauma is because of the bilaterality of the ocular trauma, and it also disappeared by 2 months. The exact origin of this disc edema may be due to a head injury, which is not evidenced by radiological investigations. This graph shows the incidence of RAPD, which was very much higher in group 1, that is, patients who had both a concomitant head and ocular trauma. We also analyzed whether this RAPD had a visual outcomes in the patients, where we saw that in group 2, 21 patients had RAPD and all of them had an intraorbital or canalicular injury. Of this, 6 people did not improve and 15 showed improvement. For some patients, orbital nerve decompression was also done. Visual acuity improvement in patients with bony orbit involvement. In group 1, blowout fracture was the most common, and group 2, medial wall was most common, and this graph also shows the respective improvement of the patients. As mentioned earlier, we also took into account whether the lid involvement had an influence on visual outcomes. In group 1, 56%, and in group 2, 75% of the patients showed an improvement in visual acuity. Discussion: presence of head trauma in patients with papilledema had a poor prognostic factor, and the results are statistically significant. The presence of RAPD in patients with head injury had poor visual outcomes, and the results were statistically significant. And the review of literature also showed that RAPD grades were associated with poor visual outcomes. In our study, we found that bony orbit involvement affected the visual outcomes in both the groups, even though the results were statistically insignificant. And we also concluded that visual acuity at the end of 2 months in patients with lid injury improved, and the results were statistically significant. So these are our conclusions from our study, that when there is a head trauma which happens along with a concomitant ocular trauma, it adds to an important prognostic significance. Presence of papilledema in the presence of head injury is a grave prognostic factor when we take into account the visual outcomes. RAPD, if present in association with head trauma, is a more ominous sign. Bony orbit involvement, if present along with a concomitant head injury, decreases the visual outcomes, and lid injuries did not decrease the visual outcomes in our study, irrespective of what group the patient belonged to. So we conclude that papilledema, RAPD, and bony orbit involvement are the factors which predicts the visual outcomes, and these are the 3 factors which we took in our study who had a concomitant head and ocular trauma. These are my references. Thank you.
A very nice study. I have a question. You have mentioned an RAPD is a poor prognostic factor. So did you grade the RAPD? Have you used a neutral density filter?
We just, at the initial time of presentation, we used it and we just graded it, ma'am. Clinically only we saw the patient, ma'am. we graded it accordingly.
Because it's very difficult to know what is clinically, like how will this affect the prognosis, right? If you don't
Yes.
grade it with a neutral density filter. That is number one. Number two, how did you manage these patients for the RAPD?
Traumatic. Most of the cases were due to a traumatic optic neuropathy, and in some cases, optic nerve decompression was done, as we mentioned, whereas the other patients were managed by using steroids in cases where it could be managed conservatively.
Okay.